This is 43-year-old male with esophageal submucosal tumor, which is close to the EG junction. EUS-FNA will be performed by Dr. Fukami.
Hello, welcome. I have Professor Yozawa and Professor Wang helping me doing this case. So this is a young gentleman who had the health checkup and underwent upper endoscopy, and they noticed this the nodule, the very overlined by smooth normal esophageal mucosa, squamous mucosa, and it looks like it's more stiffer nodule. So it was a submucosal tumor. And the appearance was rather small, but as you noticed on the CAT scan, it was a much bigger appearance. The enhancement was kind of moderate. It was not hyper-enhanced nodule. So the main question is to identify what the reason, I mean, what the nature of this tumor is. The first things is it comes out if you see submucosal tumor in the distal esophagus is it could be a stromal tumor, benign stromal tumor, mostly leiomyoma. That could be the duplication cyst. It's tend to be softer. I don't know exactly what was done. I know there's no biopsy done at that time. And then the granular cell tumor, GCT, is another possibility. Now I'll show you the endoscopic ultrasound image. First things you see is mostly trachea. There's a strip of hyperechoic repetitive echo. You can see, and on the left side, this is subcarinal space. And if you push in, oh, thank you, Dr. Wong. You see the left atrium and a mitral valve. If you talk a little bit to the right, and this is the aortic valve. So that's a cardiac examination, but we just skip through. And the tumor actually is distal to the heart. If you see that, you can see the muscular propria layer on the esophageal wall. Let's freeze this here. Thank you. So on the right side, that's a musculus propria, and then there's a hypoechoic mass you can see connected to it, and then connects down to the musculus propria. So this is a component during endoscopy they saw this little nodule, and this is a solid hypoechoic nodule within the esophagus. And exposed portion is about 1 to 1.5. So that's what we saw. But if you start scrolling, oh, thank you. When you rotate, this is anterior to the left of the body to the posterior. You can see the left ventricle on the right side, but the tumor actually extends. Okay, out to the out of the esophagus, and if you keep rotating, this get close to the aorta. You can see the blood flow within. So this is probably originating from the fourth layer of the esophagus. However, the visualized portion during the endoscopy was the tip of the iceberg, and actually extra luminal extension of the growth with some lobulation, as you can see with a hyperechoic strand. Overall size was, could you measure, Dr. Wong? It's close to 35 millimeter in one section, so it's fairly sizable. Now, we don't know the duration of this existence, and this could have been there for a long time at the same size. So we don't know the speed of the growth. However, the gist in this location is rather rare. Most of the stromal tumor here is a benign, either leiomyoma or sometimes a neurofibroma or some other type of benign stromal tumor. Now, what would you suggest? What we should do first? Should we do?
This case,
Yeah, go ahead, Dr. Wang.
I think the size is just now we measure is up to 3 centimeter. Of course, in esophageal cancer from fourth layer, it must be most cases leiomyoma.
Mm-hmm.
But for this case, esophagus growing, some lobulated, and the inside is a little in homogeneous, and there also vascularity.
Some
So
feeding vessel
yeah,
we can see.
yeah. So for this case, if he want refer to surgery, I think maybe we don't need to FNA. But if there are some consideration, maybe today we have to perform the FMB to get larger
Mm-hmm.
tissue.
May
Yeah.
I ask a question? Why do you recommend surgery and not stir for resection?
Yeah,
This is a good indication, I think, a good option for stir.
that's a great question, Dr. Neuhaus. Is Dr. Inoue there? Where is he? Professor Inoue, would you comment? I mean, this is a rather extrophytic growth. It's getting close to the heart
Yeah. At this
and
moment,
close to the aorta.
we can recognize the fourth muscle layer close to our scope, and then the tumor is exophytic
Uh-huh.
growth. So your comment is right, but no, not a comment. Your report is right, but I think now the endoscopy push the tumor out. How about the endoscopic view?
Oh, yeah.
Regular endoscopic view
Thank
is
you.
demonstrate the
Let me show you.
bulging into the esophageal lumen.
The
So,
bulging part is rather small.
uh-huh.
Sorry, this is the oblique view, so it may be a little more difficult, but
So
the bulging part is on endoscopy and ultrasound is pretty small.
uh-huh.
And
So internal growth to the esophageal lumen is not so large, but total diameter is 3 centimeters. So
three and a half.
Yeah, we can approach submucosal tunneling approach, star or poet.
When you do stir, can you go really close to the heart?
Yes. So it's now
It's
the
just to the heart.
Yeah. So esophagus is always close to heart. Just behind
How about the
heart.
aorta? There's a very thin separation from the aorta to the tumor.
Yeah, it's okay.
It's
okay. So, no.
I would.
Esophagus is always touching to the both the atrium and also aortic surface.
Of course.
So this is the capsulated and the encapsulated solitary tumor. So maybe we can approach endoscopically. If its size is more than 5 centimeter,
Then it
so
gets more
submucosal
difficult.
approach is very difficult. Even when we dissect around the tumor, so extraction is difficult to complete it. So and also this part is the I think yes. The approach is if we approach surgically, we have two potential access route. We have to confirm its position exactly by CT scan, CAT scan. But anyway, we can approach from transhiatary or also trachoscopically. But the first approach is, I think, endoscopic. Yes.
That's great. So just to give you one more information, this is a diaphragm going close to the. You see this string muscle of the diaphragm. So it's just really lower in the esophagus.
So we can approach from the abdominal side. So laparoscopically we can approach it.
Now, if this is supposed to be a gist, with the chemotherapy with Gleevec to shrink the tumor, does it help?
So biopsy first, I think. FNA first.
Sounds great, sir. I totally agree. So I think it's most likely leiomyoma, but we have to we better characterize this tumor. So for this type of tumor, we have to get the core biopsy because we need to do the histochemical stain, especially the marker for GIST. So what we chose was 22 gauge, the Boston acquire needle. So
So I'm not a specialist of the ultrasonography, but this image is more likely to GIST, I think. No?
it's still it could be still benign tumor like leiomyoma.
Okay.
We it's hard to judge with just the endoscopic image.
That,
I mean, ultrasound-wise, there's no signs of necrosis, no cyst change, border is clear.
okay.
So,
That's the reason why we perform the FNA. No?
Yes, yes, right.
right. As you remember, Dr. Holz gave us a great lecture about the biopsy, and this is the needle with the 3 prongs. They call it Francine type needle tip. So the advancement of needle can be a little challenging, but once you have this good direction and there's no intervening vessels, you just decide to just put the needle in. Push first. And then we're gonna do a slow pull.
Slow pull.
Yep. And you go to and fro motion. Oops. Try not to go through the tumor. Good. Dr. Yoshinaga practiced how fast he's gonna withdraw, so he's doing a fantastic job. Not too fast, he can slow down a little bit. So most of the time I go to and fro motion 10 to 20 times. When I do the FNA, I usually do more than 40 to and fro motion to get better sampling. But with this type of biopsy needle, you don't need to go so many times. Okay, that's good. All right, stop. Well, that's a one biopsy. Now my strategy is look at the first specimen and see how bloody it is, what's the quality of the sampling, and then make sure that you don't see excessive bleeding. Then if there's not much tissue, not much blood, then we're going to move on to the suction method. For this type of solid tumor, we can do 10 to 20 cc suction, and then do the again to and fro motion, usually 10-20 times. Do you agree? Any
Yes,
comments?
Yes. And now you do slow pull method.
Yeah, slow pull method.
You prefer that, not
I-
suction?
Yeah, persistently it's shown that it gives you much less contamination with the blood.
Blood, yeah.
But if the tumor is so packed and tight, sometimes you need to go with the suction because
I see.
yeah.
I see. And now, many Japanese like to use this Francine type needle. How about in the United States?
Well, that's another. We're moving more on the biopsy arena, but luckily we have Shako needle in the United States. The Shako needle has a track record of acquiring good tissue. Now other companies offering FNB type of needle. And my experience has been still the Shako is the best, but
I see. But now not available in Japan.
in Japan,
Yeah.
that's what I
Yeah.
heard. So let's see with the Francine type needle. There's a tissue core. Any questions from audience?
Dr. Fukami, was it when you're doing the F&B, was it soft? Because it seemed to go through pretty easily.
Yeah, actually, I felt pretty soft. When I'm advancing, probably at the septum, I felt little resistance, but otherwise it's fairly soft.
And
Not too soft.
And what do you think about the bleeding inside the tumor? Is it?
Yeah,
like
there's a little bit of echogenic appearance, so you may be right. There may have been intratumoral bleeding happened.
Right.
So as little of the biopsy passage would be best for this type of tumor. But again, we have to get adequate tissue for immunohistochemical stain. So my bias is I always do twice at least to get the kind of insurance package. Well, how
And
many
for
passes would you do, Dr. Ryozawa?
Sorry?
How many passes do you do? Is it
Uh,
once is enough for you?
Maybe. You mean the two on the floor?
No, no, no.
Uh,
How many pass?
How many pass?
Yeah, this is the first pass we
at least
finished.
twice.
Twice.
Twice,
Okay,
yes.
you agree with that. Okay. Any other questions? Sorry, it's not too sexy, but yeah. Oh, that's too bright. There you go. That's good. So you see some of the core material, I believe.
Yes, you can get some white tissues.
Okay.
Not so much, but I think it's enough.
Are you sure? Are you going to guarantee?
Good, Dr. Fukami? Dr. Fukami, can you hear me? Dr. Fukami, we're going back to Dr. Yahagi's room, and thank you very much for your great demonstration.
Dr. Hirota, the pathologist, read for us.
Ah.
Do you want to?
です間質、結合式が採取されていまして、で細胞成分はほとんど見られないんですけれども、ごく少量の、紡錘系の細胞が、わずかなんですけれども散見されます。
So it's mostly the connective tissue with a very uniform nucleus. It's more oblong type of nucleus, and there's no atypia. So according to Dr. Hirota, it's going to be most likely benign stromal tumor. It could be still a GIST, so final pathology diagnosis will be done with the immunohistochemical stain. So the adequacy of the tissues is good, right?
Yes.
Good. So we did 2 passes with each time. The second time also a slow pull, and we got a string of the core sample. So I think it's going to be adequate.
Thank you very much.
Thank you.